Namaste. Autism is a complex neurodevelopmental disorder that affects an individual's communication, social interaction, and their behavior. According to WHO, 1 in every 100 children has autism, and during the past few years, this number has been steadily increasing. To care for them right, we should be aware of the condition, its symptoms, their needs and abilities, and the type of care they specially require. On this significant day, we have with us a very eminent panel to help us learn more about what autism spectrum disorder is, the challenges faced by our tiny humans living with it, and their parents. Introducing our specialists, Dr. J. Shyamala, Senior Consultant, Pediatrician, and President IAP CCB, Apollo Children's Hospital, Chennai. Dr. Sai Sucheetra, Consultant Developmental Pediatrician at Apollo Children's Hospital, Chennai, and Ms. Radha Nandakumar, Special Educator and Co-Founder, the Gurukulam. Thank you very much for joining us today. Welcome to our FD Live. Dr. Sai Sucheetra, why is it called autism spectrum disorder?
Autism spectrum disorder has mild, moderate and severe. So a child can be anywhere between the mild end of the spectrum to the severe end, because that's why it's called a spectrum. And the child can have, every child has different skill set. Like a child who is diagnosed autism and another child who has a diagnosis of autism may not have similar symptom pattern. Their skill levels can be very different. So it's not the same for every child with the diagnosis. So that's why it's called a spectrum. And also when a child is diagnosed to be on the mild at age 3, they may not continue to stay at the mild end of the spectrum all through. That's also something the parent should understand, that the diagnosis can change over time, because the growing brain can learn, adapt and get better skill level, or if there is any medical issues that are also there in the child, so there can be a little regression also possible. So that's why it's called a spectrum, because the symptoms is very variable and there is no two child with the same kind of pattern of behavior. And also adding to this, children can be high functioning, low functioning. That was in the previous DSM-4 criteria that used to call children as high functioning, those who had very good skill level but have a behavior difficulty, but they have very high IQ. And the other side, there is a child who has behavior difficulty but low skill set. There's a cognition delay and they would be called a low functioning autistic child. So between these two also there can be very mild differences also. So all through that spectrum the child can fall anywhere between. It can be very high skilled, or they can have a very low skill set, and they can have additional talents and skill. So it's a very variable, complex mixture of symptoms. So that's why it's called a spectrum.
Dr. Shyamala, a 3-year-old boy Anwar comes to your hospital for routine vaccination. The mother, in passing remarks, says that he is slow to speak. What, in your opinion, would be the red flags for this child, if at all?
The mother may not complain to me that the child has any worrying features, but what would strike me when I see the child, that he seems to be living in a world of his own. I see that the mother is talking. Sometimes there might even be an elder sibling. And a very typical thing we see in kids is they fight with the other kid, or they tickle him or something like that. Here there would be no kind of interaction. And they seem to be playing with things they want, maybe have a gadget, maybe running around. They may be making sounds which are not really, they are just sounds, they are not words. And by 3 years, I would expect that they would be speaking small sentences and string along at least 2 to 3 words. So if he's not able to do that, I would ask the mother leading questions which would make me suspect that something is wrong with this child. Red flags would be if mother says that he doesn't indicate his needs to me, he just points or he just makes funny sounds, and mother has to anticipate that he's hungry or he wants this. So in effect, he's not really communicating with anyone. Sometimes they are very sensitive to loud sounds, or they seem to have stereotypic behavior. They keep playing with the same objects all the time, and in effect, he's not what I would expect for a 3-year-old. His vocabulary would be very restricted. And again, I don't put a label on the child at the first contact. I would probably ask the mother, are you sure this child is hearing what you're saying? Because sometimes if there is a hearing impairment, if we fix the hearing with the hearing aid, or he may just have a glue ear, and a simple insertion of a grommet may actually fix this condition. And the parent does not want to hear at first contact that your child may have autism. So I sow the seed of doubt, and I ask for a repeat visit, and I broach this topic again, and I ask the mother to look for certain signs. And if I'm not happy with the progress, yes, definitely I would ask for further intervention or evaluation for this child.
So speaking of signs, as a parent, what are the signs and symptoms that a parent should look at to suspect even autism in their child?
Yeah, so as I said, if the child does not indicate needs, but only pointing or making sounds, and we have to think what they want, or he goes on playing with the same object each time, and he makes loud sounds or cannot bear loud sounds, and he does not seem to interact with elders in the environment. And when he's called, it's very important, response to name call. When he is called, he does not turn, and often they put it down to he is actually very engrossed in whatever task he's doing. They don't think it's anything abnormal unless somebody outside points it out to them. So if they're not responding to name call, yes, there is something wrong. We have to investigate that.
Ms. Radha, from an educator's point of view, what are the red signals that you look for in the play school environment?
We see the symptom developing only around 2.5 or 3 years old. So the play school is the right place where they can actually catch the condition earlier. The first thing is like these children, they lack eye contact. Which is very important for any conversation to develop, for them to understand conversations and all communication skills. The first thing that any child should pick up is sustained eye contact, which they lack. Second thing is, as doctor said, it is response to name call, and they have repetitive play behaviors. They can engage themselves in one type of play for many hours, and they lack joint attention. When they find something very interesting, they don't go and share that happiness with somebody else. And we find them, some of them doing play like jigsaw puzzles and all very well, but they don't allow anybody to interfere into their play. And one more thing is frequent meltdowns for no reasons, and they're very much attached to some object which they always like to cling on, keep with themselves. And one more thing I want to say is, even there are some children who pick up speech, and there is a speech regression during this time. And in some cases, the speech is delayed. In some children, even though they have a good vocabulary, but the use of language, like to make use of that vocabulary is restricted. And if they want to ask for their wants and needs, if they don't point it in a normal way with one index finger, they just try to wave their hands towards that, or they hold some adult's hand and then they would reach that hand to the object that they want to take. These are the symptoms that the play school people and because the most of the families are all nuclear families, wherein the elders of the families are not very close. They're not present there around to tell that there is a deviation in the child's progress or development. So the play school also should be very aware of this, and they should point it out to the parent as early as possible.
Now, just to add on to what Radha said, something that we always see at 3 years is they like to imitate some favorite person in their setting. They want to imitate their teacher, or they want to play like a doll, and so role play is missing. And also, like Dr. Radha said, they don't share any interesting thing. They don't bring the parent and say, this is what I saw, and that kind of behavior we don't see in these children.
So, Dr. Sai, is there any diagnostic test that can help detect autism?
Now, diagnosis has a lot to do with observation than just a screening tool, because observing the child gives a lot of information on the red flags, and also doing a detailed history from the parent gives insight into how the child has developed over the years. Now, early markers for autism can start as early as say 4 months, 3 months, when the social smile is delayed. A delayed social smile is probably the first marker. A lot of parents can, in the history they might say, my child never made eye contact, looked into my face, and smiled even at 6 months. So a delayed social smile, and also a mild motor delay. That is, walking by age 12 months is expected, but some children, later getting diagnosed as autism spectrum disorder can start walking at 15 months or 17 months. So there is some significant data that we get when we do the history, and a very valid point here is there might be a mild motor delay that can be told by the parent, and also a delay in the social smile. And on observation, like when we let the child play for about an hour in the playroom, get a lot of information on initially when the child gets into the playroom, they're very excited with the colors and a lot of toys in the playroom, so they appear to be very hyperactive and less attention. But even when you try calling them by the name, they never look at your face. They really don't make an eye contact. They're so happy with the play environment that when you give them some time to settle down and allow them to play with their favorite toys, and after that when you try making eye contact, some children do give good eye contact, but even in that setting, the child is unable to make eye contact, the child does not engage with you one-on-one. When you try sitting next to the child and initiate a conversation, the child hardly looks at you but is so engrossed in solitary play. So these are all very important markers that go in for diagnosing an autism behavior. Now, also stereotypic pattern, like fixed pattern play, like aligning objects one behind the other. It's natural that a child which plays with a toy train will align objects one behind the other, but not every random object that they get they will align and play. So there is a fixed pattern of play, like you give them a stacking ring. It's very natural the child stacks rings and plays, but a child with an autism pattern behavior would probably want to align the rings one behind the other and play, and not stack and play. So these are all very important observation points. And also a very typical history of a child being all right at age 1. The parent might say, during the first birthday my child was waving bye bye, my child looked at me eye to eye, my child did make one word. They said appa, amma, they made a word and called me. This might have been there at age 1, but at age 2 to 2.5, the parent gives a typical history of my child appears to have regressed. My child appears to have forgotten how to call me, has forgotten to say bye bye. So these are all very important diagnostic pointers. Now these are all observation points, but a diagnosis is also through a screening tool. The screening tool that we usually use in our office practice is the MCHAT-R. That is a modified checklist for autism in toddler, a revised edition that is available as a free tool even in the internet. So that is the tool that we use for scoring the behavioral difficulties, and that is parent based. So these questions are asked to the parent, and it's marked on the questionnaire, and a significant score higher than 8, or very important behavioral difficulty questions. The parent answers yes, these are all behavior difficulties. So that goes into screening the child. It's not diagnosis, it's screening tool. So there is a behavior red flag, so child is screened to have a behavior pattern that is more towards the autistic side. And then the next step is to do a detailed diagnostic evaluation. The diagnostic evaluation is using a tool called CARS-2, that is Childhood Autism Rating Scale, second edition. This is also available. A lot of this information is available in the Google, and this is a diagnostic evaluation. And it's also parent based, and it takes a lot of time to complete this questionnaire. And it's a very detailed evaluation of the behavior, and a very high score indicates that the child is diagnosed to have autism spectrum disorder. So the basically the diagnosis is observation based, and then using a screening tool to say if the child is yes into an autistic pattern or not, and then if there is a pattern that is observed, then we do a diagnostic evaluation.
Even during playtime, a toy which any other child, the way if we give them a car to play with, they would try to move the car and then play with it. But these children, they would just spin the car and then observe it, or just observe the wheels moving. They will not use the toys appropriately as any other child would do.
Which is a very relevant observation. So, what causes autism actually, Dr. Shyamala? Anything that can be done from the parent's perspective or from the medical perspective to prevent ASD?
Autism is a complex disorder. So while there may be genetic etiology, there is also believed to be some influence from the environment. So we talk about epigenetics. So it has to be a combination of the two. So while there are some about 100 genes that may be associated, there's no specific gene that say if you pick this then you have autism, except some syndromes, like Fragile X syndrome. Largely, we don't really know. That's the true answer. But there are some things that prospective parents can do to reduce the risk of autism. Say, elderly parents, they believe that is a predisposing factor, and mother's stress levels. If the mother is very stressed in pregnancy, then that's something that she could avoid. Folate supplementation, or vitamin D supplementation, and omega-3 fatty acids for the mother. These are good things. Good control of diabetes, good control of hypothyroidism, and other risk factors, hypertension. So in effect, the mother's health should be good. She must avoid taking agents like certain medications like antidepressants, anticonvulsants like valproate, radiation exposure, exposure to heavy metals, toxins. So these are all common sense things. And also through the pregnancy, just try to see that she's not she's very well maintained, and she's appropriately vaccinated, and at the time of delivery there should be no stress, so no hypoxic insult. So in effect, if you look at these things, then it certainly reduces the risk of autism. And we don't know why, but males are at a higher risk for autism, at least 4 times higher than females.
So, Dr. Sai, are there any prenatal or genetic tests that can help detect autism?
Unfortunately, there are no prenatal or genetic tests that can diagnose autism. But I mean, as Shyamala Madam said, there is a lot of precautions that pregnant women should take, because we see that the incidence of autism is on the rise. It was not so about 2 decades ago. So there is definitely some lifestyle changes that have happened in these 2 decades that are that's probably contributory to the higher incidence of autism spectrum disorder. If when our parents ask, first child has had a diagnosis of autism spectrum disorder. Now, what about the second baby? So when the first child is diagnosed with autism spectrum disorder, it is definitely worthwhile doing a complete genetic evaluation. We do recommend that they meet a genetic specialist and do a pedigree, and look for any distant relative or anyone else in the family with a child with autism, and look for genetic causes and rule that out in their child, because that can protect the second child as well. So there is no particular prenatal diagnosis, but doing a genetic workup for the first child when the parents are planning to have another baby would definitely be on the recommendation.
I would like to add something to what Sucheetra said. One very big preventive measure is avoiding use of gadgets both by parents and the child. For whatever reason, post-pandemic, we are all with gadgets, and that's reduced quality time and reduced human interactions. And they say that it takes a village to raise a child. And often grandparents who are a positive influence on the growth of a child, they are missing. Or if they are available, they are probably in front of screens themselves. And often parents resort to iPads and mobiles to teach the child, their tables or nursery rhymes. If, in fact, the American Academy of Pediatrics recommends no gadget exposure less than 2 years. That's an ideal world. But I know parents who in practice avoid exposing their child to gadgets, and it takes a lot of work, believe me. But at the end of the day, I think these kids turn out so much better than the kids who learn from gadgets. So if we, as parents, if we take it as our mission not to expose our kids to gadgets, and as doctors, if we can educate young parents to avoid use of gadgets, I think it would go a long way. I won't say it would take off, but largely it would reduce the amount of autism that we are seeing.
So, Dr. Shyamala, who would you refer to once you suspect autism? What would be the next course of action?
Once I think that I'm dealing with a possible autism, like Sucheetra mentioned, I would probably give them a screening test to do, and then I would probably refer to a developmental pediatrician, and I would, as I said already, get the hearing evaluated, because if a baby cannot hear, then he cannot progress in therapy, or it may actually change his diagnosis. So I would first make sure that there is no auditory issue here, and then refer to a developmental pediatrician.
So, Dr. Sai, while we're talking about regression and development delays here, there are some children or individuals who have been clinically diagnosed to be under the autism spectrum, but do excel in certain activities. Why are they still clinically categorized like that? What is your thoughts on it?
Autism is a spectrum disorder. We started off discussing about this. It's a spectrum, so children can come anywhere between the mild, moderate, and severe. And children who have mild behavioral difficulties, still in the autism diagnosis, but mild behavioral difficulties like they would have acquired speech, verbal ability, but would still not make adequate eye contact, would still not make adequate response to name call, might prefer solitary play. So these are the only behaviors that you might spot at age 5 to 7, but the stereotypic play pattern or a lot of sensory overload may not be there, and these children actually do well in a classroom environment and can do a mainstream schooling, and they can be extremely gifted because they can do mathematics very well. Some children have other skills like they can be extremely talented in music. So these are children who are later called as the high functioning autistic children, and previous criteria, the DSM-4 had this high functioning, low functioning categories, but now the DSM-5 has only one diagnostic name, the autism spectrum disorder. The spectrum is mild, moderate, severe. So children on the mild end of the spectrum can have a lot of good skill set, and they can be extremely gifted children. While they have their behavioral difficulties, they can still continue to have a very high skill level and can have good IQ and can do very well in academics also. While children on the moderate and the severe end of the spectrum might need a support to complete academics. So answering your question, children on the mild end of the spectrum, that is previously called high functioning autism, can do very well despite their behavioral difficulties. They can have a very high IQ and they can accomplish very well in academics also.
I'd like to emphasize the fact that whether they are in the mild spectrum or the severe end of the spectrum, the unifying feature in all this is their social inability and their inability to relate to the outside world, and they seem to live in their own world. So the social skills are quite inhibited.
we see some children doing the calculations very quickly, very quick calculations, and then there are children as early as 3-year-old can read a lot of words, and they are very good in drawing. I mean, like painting and drawing. They can see, they can pictorially memorize something, and then they can draw it as it is. These are things that some of the children with autism exhibit.
Adding one point to Madam Radha, this is a barrier in making a diagnosis, also making the parent understand that the child has an autism spectrum diagnosis, because a lot of parents say that my child is extremely gifted in academics, he can name the capital of any country, and my child can do tables. Even a 3.5, 4-year-old child who can do 4-time table, 2 table, and they say in addition, subtraction, division. My child knows everything. So why is he diagnosed autism? So the diagnosis of autism is again on based on behaviors, and not just the IQ level of the child. Children with high functioning autism, as we previously mentioned, can have very good IQ, can score very high on the IQ scale, can be categorized in the gifted category also.
Sometimes people have this feeling that when the child is branded as diagnosed as a person with autism, they immediately look for something that child excels in. So they come and ask, like, my child is a person with autism, is diagnosed as like with autism, what is that he is going to excel in? So they are always looking for something that the child is going to show extraordinary brilliance in.
And since autism is a spectrum disorder, the child can have behavior symptoms with cognitive delay, or behavior symptoms without cognitive delay also. So without cognitive delay, just behavior symptoms can also be present. So children who are diagnosed autism spectrum disorder can actually have a very good IQ level.
And Dr. Sai, speaking from the parents' perspective, are they required to have or to educate themselves with some special training to handle children under the autism spectrum?
Yes, I think it's very important that the parent caregivers, they are the caregivers all through the day, and a base training for the parents will help them work with their child in the home environment, because the child spends about 3 hours in the play school, about an hour and a half in therapy, and the rest of the time the child is at home. So stimulation to develop speech, to reduce sensory overload should also happen all through the day. It shouldn't be only restricted to the therapy time. So training the mother, the parent, to give parent-based home intervention is very effective, and it is also recognized as one of the evidence-based practice methods in the treatment, in the intervention of autism.
So speaking of intervention, what intervention should be done after suspecting autism in the child?
So once there is a red flag identified in the child, the next step is the diagnostic evaluation, and after the diagnosis, the family is counseled on what to look for and how to get the child started on early intervention. The early intervention, what we call, is the first intervention that should happen, and that is starting the child on therapies, the occupational therapy, speech therapy, and behavioral intervention. So there is a assessment that precedes all this. There is a skill assessment, as in what to do. For each child has an individualized need. So we individualize the therapy plan, and it is executed by the therapist. And now again, talking about intervention, there is a role of medication, but not before age 5. After age 5, depending on the attention span, the time that the child can have sit in the classroom, and how much time the child can stay in a task, hyperactivity levels, and then we think about planning medication. But to start off with, early intervention with therapies, and also training the parent to implement home-based therapy activities. So there are about 27 evidence-based practices that have been identified worldwide, and the AAP recommends that these EBPs, that is the evidence-based practice, are they give good clinical outcomes.
Speaking of education, can parents send their child who's been diagnosed with clinical autism to a regular school, Radha ma'am?
They must send them, because in the early childhood, the child can learn a lot from the peer group. So they must send them to mainstream school.
So if we're talking about mainstream school, can the curriculum or should the curriculum be customized and imparted separately to these children?
While they are in the kindergarten, actually 0 to 2 years is considered as sensory motor stage, wherein every child learns through the senses. And because these children have, most of them have sensory integration dysfunction, they are a bit slow in gaining the perceptual skills, that is visual perception, depth perception, spatial perception, which are all very essential for them to actually learn in the future. And also there is deficit in the attention span and sitting tolerance. So the early curriculum, that is early classes, they should be having more stress on the pre-writing, pre-numbers, pre-reading, and the perceptual skills, along with the attention span and the training them in the sitting tolerance, which would be the basis for them to learn in the future classes.
And speaking of curriculum, how should they be evaluated? Should there be a different evaluation system in schools for children with autism?
See, while some of the children are able to grasp the subject very well, but because of their attention span or because of their sitting intolerance, like sustained sitting tolerance, they are not able to perform the conventional method of evaluations.
Adding one point to the special educator's view, even while during assessment time takes about an hour and a half on multiple days. So during the assessment, what we observe is child having autistic behavioral difficulty will find it very difficult to sit for more than 10 to 15 minutes. So after every 30 minutes of assessment, we would recommend giving the child a timeout to either they self-stimulate themselves on the ball. They would like to rock themselves on the ball, just run around the playroom for a couple of minutes and then come and settle down. They would need blue lights, calming music. So for me, completing a successful diagnostic assessment will need to equip the playroom with all these kind of sensory and objects that can help the child self-soothe in themselves. So the child sits and cooperates for the assessment, so we can complete it. So I think the same thing would also be needed in a classroom setting, where there are regular, typically growing children and children with behavioral difficulties like autism pattern would need a mixed classroom environment where there are sensory support systems which can help the child get over the meltdown and then get back to academics.
So if there's any one important message that you would like to share at the end of this session to our viewers, what would it be? We'll start with you, Dr. Shyamala.
So once we have made the diagnosis of autism, finally there is a team. There is a team that develops with that works with the autistic child. That's the developmental pediatrician who is overall supervising the child's progress. There is a behavioral therapist. There is a speech therapist. There is an occupational therapist. Yes, but we must not discount the importance of the family in the whole thing, because as Sai was saying, they probably spend an hour in therapy and 3 hours in play school. So unless we reinforce whatever is taught in the therapy sessions and replicate the same environment at home, we are not going to get a successful outcome. And often we see that the child does not fit into the session immediately. Then the family says, no, he doesn't like therapy, and they are either irregular for therapy or they interrupt therapy sessions because the child doesn't seem to be doing well. So they have to allow the child enough time to settle into the routine. Sometimes it might take a month, it might take 2 months, but the wait is worth it. So the family has to stay with the same team to ensure optimal outcome. And second is regularity of attendance to these sessions. So many times they make excuses saying the child is not waking up, he's not finished his breakfast, so they're irregular to the therapy session. So mandatory regular attendance to therapy sessions should be emphasized. And the third, and that is the most important thing as far as I'm concerned, is the mother's involvement in the whole therapy process. So unless the mother is involved in the child's progress, I think what anyone else, what mother can do, no one else can do. So there must be a lot of encouragement, involvement. So if the mother is just busy with her own routines, but allows only the therapist or the caregivers at home to oversee the process, the outcome would not be optimal. I'm sure Sai agrees with me on this. We have had many situations when we've had to encounter problems in this regard.
Yes, many children get referred early, and the start of the therapy happens very promptly, but then there is no consistency in the therapy. The parent either loses interest to attend therapy sessions or doesn't implement home-based programs. That's when myself and Dr. Shyamala, we would discuss about the child already enrolled in therapy but not completing therapy, they're not progressing on their skill level, or discontinuing therapy halfway through. So the best clinical outcomes are achieved when the parent brings the child for therapy early, not waiting and watching, putting the child in school and then waiting the child to develop on its own, and then at age 4 to 5 they bring with a lot of desperation. You know, my child is not at all talking, it's already a 4-year-old and now we need to do something about it. But always clinical outcomes are best when the therapy is started early. So early referral and consistency in therapy from the parent end, implementing home-based programs is very important for good clinical outcomes. So from my side, it's the early referral from the child's general pediatric team, and from the parent end, good cooperation to complete long-term therapy is probably what I feel is very important.
Ms. Radha, what would be your important message that you would like to share?
I would say earlier the intervention, better the prognosis. That is one thing. Second thing is the parent should accept the child as early as possible. They should not lose out time on that, on acceptance. The third thing is a child is a child first. All other things come later. So they should not deprive the child of the childhood activities just because the child is branded as a child with autism.
Thank you very much, Dr. Shyamala, Dr. Sai Sucheetra, and Ms. Radha for sharing your valuable thoughts on autism spectrum disorder from the clinical and educational perspective. Let us stay aware and give our children a wonderful world filled with love and hope. Thank you very much.
Thank you.